Welcome everyone to the Community Health Nurses of Canada webinar series. This is our third webinar, I believe, and I'm thrilled to be here. My name is Donna Jepson. I'm the president of the Community Health Nurses of Canada, and I have the honor to introduce our guest speakers momentarily. But I just wanted to acknowledge that today I'm calling in from Vancouver, and I'm calling from the traditional territories of the Musqueam, Tsleil-Waututh, Squamish Nation. If anyone else wants to add their traditional territory from where they're calling in today, please feel free to do that in the chat. Before I turn it over, I also want to let everyone know, if you have not heard, that we have our national CHNC virtual conference coming up very soon, June 8th to 10th. The registration is open. It's 3 days and we have early bird registration. So if you wanted to save a bit of money, please go to the CHNC website. Some housekeeping. If we could ask everyone to mute during the presentation, but you will be able to unmute yourself and ask questions, and we will also be monitoring the chat. So just very briefly, our speakers today are Cheryl Van Dalen-Smith, who is a nurse educator at York University and has a background in public health and also home health. We have Karen Curry, who works in professional practice at the Victorian Order of Nurses and has expertise in home health. I also want to acknowledge another presenter, Tish King, who is a nurse educator at the University of Saskatchewan. Tish, are you calling in from Saskatoon today? I'm not sure. And then Laurie Bowen is calling in from Saskatoon and is a nurse educator at the University of Saskatchewan with a family practice nurse background. I am going to go on mute now and turn it over to our speakers.
Great, thanks so much, Donna. And we're really pleased to be here to speak to you about the standards from CHNC. We are the small but mighty Standards and Competency Committee, one of the committees of the Community Health Nurses of Canada. So we always want to share and get the word out about the great resources that are available for you to support your practice, no matter what area of nursing, community health nursing you're working in, as well as to share it with folks who may just be learning about Community Health Nurses of Canada, or also learning and becoming more aware of the resources and supports we have to support and build a strong community health nursing voice in Canada. So we're going to be talking today, and I wanted to open up our poll. We wanted to get a sense of who are you? Who's joining us today? So we had a few questions because, you know, these competencies have been around since 2019, but then we all know what happened after that. So we've been really trying to engage and to talk and to share it with the community health nurse members. So that's why we're still talking about it, to make sure we have some full understanding and awareness of these tools. So we wanted to get a sense who's here. So we can, I'm just going to look at the poll. Maybe, I'm not sure, I think you can leave the poll up as people are still kind of trickling in. But we have, are you a member of CHNC? We have, most people are yes, and we have about 2 out of the 17 that said no. So welcome to you. I'm glad you got the information through your networks, and certainly hope you take some nuggets away to consider becoming a member and joining CHNC. The other piece we wanted to get a sense of as we were talking about these standards is, are we talking to people who already know about them, or are we talking about people who maybe just newly introduced, or maybe heard about them but maybe don't yet have a copy, but have been introduced to them at other forums? So It's really quite interesting. It is almost half and half. So we have 11 people have their own copy out of 19, and then we have about 8 that do not have a copy of the standards. So we'll talk about that at the end or during our presentation, where you can find access to those standards and information to support your practice. So thank you for taking the time to fill out that poll. This presentation, we wanted to have a dialogue and discussion for this webinar. We wanted to give some information about the standards, but we also wanted to share some stories because we know it's been a rough couple of years in nursing, and we're all tired and still trying and doing our best and doing our good work every day. And we recognize that you're coming today, maybe in the middle of your workday. If you're in the Maritimes, you're at the end of your workday. If you're out west, it's your lunchtime. So really grateful for you to take the time for yourself to get some information and to spend some time on your own professional development and networking. So we're going to be asking you some questions, some reflections. So please feel comfortable coming off mute and sharing. That's what we're here for. We want to share and hear and learn from each other. That's the purpose and big intent of this session. So I'll just review briefly our objectives for today. We want to provide a brief overview of the revised standards from 2019. We picked out a couple of the standards to kind of focus on, and we'll be talking about capacity building and health equity. We also are going to spend some time reviewing the 9 new practice expectations that were researched and implemented into the revisions for 2019. And we wanted to invite you to reflect on your practice experiences, share your perspectives and stories as we go through this session today. We also want to acknowledge the great work that you do. It takes a lot to be with our communities, to be with our families, our clients, but it's such a big important part of what we do is how do we build relational practice, no matter what area of nursing or education or leadership you're in with community health nursing. So we're going to talk a little bit about that as well for you to reflect on. For those of you who have not seen or have your hands on a hot copy or have downloaded or have a copy of it, this is what it looks like. We did a lot of promotion in 2019 at the conference. I believe it was in New Brunswick, our last face-to-face conference when it was released. So this is the document that was put together to support and revise the standards of practice and the professional practice model for community health nurses. So of course, we're going to promote Get Your Copy. It's available on the Community Health Nurses of Canada website. And always the standards are available. You can ability to purchase a PDF or a paper copy. And we are working to make these standards more accessible and open source as we work through our organization. Right now, there is still a small cost to the standards. So just to set the tone, why do we have community health nursing standards of practice and why do they matter? As with any area of nursing, we want to identify, what's special about community health nursing. We want to give nurses doing community health a voice to say, this is why being a community health nurse is important. We want to be able to set some practice standards for excellence. It helps support our foundational standards when we're looking at our certification with CNA. We do have a community health nursing certification for CNA. So if you haven't taken that, I would encourage you to check out our website because we are really wanting to engage and promote folks in their personal learning and really encouraging those home health folks who may be joining us and family practice nurses, public health nurses, no matter what area of practice. If you weren't aware, we do have a certification. It also sets the criteria for safe, ethical care. It helps support the scope of practice of what we do, what defines us as a specialty area. It helps support organizations when they're building their professional practice reviews, reviews of yearly audits to see, you know, are you doing what it's expected. We've been encouraging, some organizations have incorporated the standards of practice into those reviews. And of course, it supports your professional development to say, be able to voice and stand up that, you know, I'm a home health nurse or I'm a public health nurse, and I went through the certification to support my practice and to help me grow as a community health nurse. Oh, I see something is missing here. I'm sorry about that. I just looked at this previously. Oh, it's fancy. I'm sorry. I didn't realize it was a fancy slide in the middle of this. I'm thinking, where did the home health go? So wanted to set the context that, you know, obviously community health nursing, it encompasses different categories, different areas, domains of practice. Public health being probably one of the most recognized and known when folks say, hey, community health nursing is public health. Public health is a specialty area and focusing on promoting and protecting, looking at populations. Home health, which is my background, as you can see, I work for Victorian Order of Nurses. And home health focus on prevention, health restoration, maintenance, palliation, capacity building, client teaching, and focuses more on the individual in their home setting or in a community clinic setting. Nurses working in primary care or family practice, they're doing a full scope of preventative health screening, health education, comprehensive assessments, chronic disease management, case management, anywhere from wound to immunization. So the specialty is quite broad, and also there may be nurses working in parish nursing, school nursing, and other areas of practice. So this is a really quick overview to, if you haven't been introduced to the standards, here they are. So standard 1 is health promotion. Standard 2, prevention and health protection. Standard 3 is health maintenance, restoration, and palliation. Standard 4, professional relationships, capacity building, health equity, evidence-informed practice, and professional responsibility and accountability. So no matter what domain of community health nursing you're working in, the expectation is that you should see your work reflected in these standards. Obviously, certain areas you may find have more of these than others, but certainly we really want folks to reflect and think about, how do I demonstrate each of these standards of practice in my work? We also have the community health nursing standard practice model here, and this looks at the different competence standards and how they all relate and how they all build on each other as we go through and looking at the different criteria that are involved in the particular standards. So I'm going to pull out one particular standard. As you can see in the brackets there's 17 indicators if you were looking at the document as to how you should be demonstrating these in your practice. So capacity building is when the community health nurse partners with the client to promote capacity. The focus is on recognizing any barriers to them obtaining optimal health, looking at system areas, looking at what they can do individually to advocate health teaching, and help them to mobilize and build on their existing strengths. Obviously, in capacity building, it's a co-relationship with the nurse working with the individual and families to work on how they can support their own health, helping them to build capacity, recognizing their strengths, and supporting them to be independent as possible. The next slide just gives a demonstration of how the different areas of public health may demonstrate this. So a public health nurse demonstrates building capacity by working as a member of a health action team in a high school to mobilize parents and students and administration, maybe bringing in community partners to look at what are the strengths at that particular school, to prioritize, do some needs assessment, and develop some implementation plans to develop gaps or address any health issues as we see and hear, particularly perhaps looking to how to evaluate the growing use of vaping amongst the youth and to identify areas to address that. From a home health perspective, this would be anywhere from encouraging a mother and teens to work together if they have a child that's home that may be a chronic complex case, maybe helping them to support the grandmother to be at home, looking at range of motion exercises. They may be looking at helping them to deliver an antibiotic to a family member at home, maybe helping them to ensure they can, what's the best visit time for them, and also as well, encouraging end of life communication, awareness of resources in the community to support them once the nursing services are completed. When we're looking at primary care and family practice nursing, a big part of building capacity is empowering the clients and families to understand what's available in their communities for resources, looking at across the lifespan, and advocating for vulnerable populations such as youth, LGBTQ2, older adults, or particularly clients who may have across the lifespan of any chronic conditions or medical conditions. So as you can see, building capacity goes across all the different specialties of nursing, of community health nursing. So now is your time. I think I'm just keeping an eye on my time here, but I think I maybe have to speed up a little bit. But I'll just briefly open it up to see from folks in the crowd. Describe a practice situation where you demonstrated building capacity in your daily work. Feel free to come off mute, share a practice pointer or pearl, as I like to call them, of when you demonstrated building capacity. See, we came here, we wanted you to work or to reflect and chat, not work necessarily. So there's 33 people on the line. I'm sure some of you can think of a situation where you would build capacity.
I'll go ahead.
Great. Hi.
I'll be front of the class today.
You do that. Fantastic.
My name is Coral Tipton. I'm a community health nurse in Leetwat, currently in Leetwat, Mount Currie, in British Columbia. I think capacity building's the tenet of all my language and my nursing style. So I practice it daily, and it's just so amazing to watch when it's all sort of like motivational interviewing. It has a very profound and immediate response. So I'd say capacity building for me in the most recent experience was this may seem unconventional, but this is where I find working for Indigenous folks and meeting people as I'm walking or riding, meeting community members and wanting to have these quick conversations around health. So the capacity building thing for me would be knowing this gentleman, just encountering him on the street, him talking about what his values are, what's important to him in a nutshell, and my being able to respond by capturing just being able to I'm knowledgeable about the cultural ways of the region, and I'm knowledgeable of the outlying communities and what the message is from leadership. So to be able to, I was able to reflect back to him how what he was saying was a form of, it was a social capital, it was a social currency what he was doing was actually could be paid work. So that to think about that it's culturally appropriate to go visit elders, do things for them. But I introduced the idea, well, that we also need workers in these roles, but I introduced the idea that this could be, that this volunteerism of his could be something, and that he has a readiness for stepping into a paid position for what is kind of known as just living the Ntakmin is the Uqamich word, the traditional language here for living the way, the Litwat way, the Statliam way. Yeah. So I'd say that.
That's wonderful. See, there you go. Off the top of your head, work, you're able to relate to how you demonstrate your standards of practice. And you may not have even been aware that, hey, by doing this, I am really supporting my community and I'm using all my skills and I'm looking for any opportunity to build that. So thank you so much for having courage, for speaking up and sharing your story that others can learn from. Thank you so much, Coral. And I see there's a hand raised as I'm stopping to reflect. Sherilyn, did you have a story you wanted to share or a comment?
Hi there, yes. We know that in community health nursing, very often we do deal with one-to-one with clients, but my example is actually a group of people. I work in population public health. From a population perspective, I am one of the clinical nurse educators and was providing support as we were doing COVID case and contact management. We had amazing opportunities to work in capacity building. And one of the prime examples that came to my mind was we worked with a lot of our farms and our businesses because we have a large amount of temporary foreign workers here in the Fraser Valley of BC. And so when our temporary foreign workers either tested positive for COVID or were close contacts of COVID, there were some very strict isolation guidelines that we put in place. And so mobilizing and capacity building, working with the businesses, especially the farmers who house their temporary foreign workers, and looking into resources for them and assisting them through that, was a wonderful experience, and I think great reflection of capacity building. We had a social worker involved, we had medical health officers, communicable disease nurse coordinators, as well as nurses. It was a really team effort, and working with the businesses to identify their strengths and what they could share together with one another and what they learned from one another was excellent. Thanks.
Great, thank you so much. Again, a different area of practice, showing that the capacity building is kind of forefront, and you're able to demonstrate that. Thank you so much. So we'll move on to just have a discussion about another, I think how we're doing for, I'm just checking my time. I'm almost done. So health equity, but I think the discussion is where we really wanted you to reflect on and think about. So standard 6 is health equity. I think, many of us, no matter where we work, this is becoming a part of our language, part of our learning, if it's new to us. I think community health nurses have always been aware and living health equity and awareness of the social determinants of health and how to engage and to advocate. However, now it's really pulled out. And this is where we try to work with and advocate for healthy policy and focus on advance health equity as an individual and a societal level. And again, that social justice lens, that health equity, that partnering across the domains of practice are so important. And I think many of you have seen this cartoon or this image to demonstrate the importance of how do we really work between equality versus equity. So in similar vein, I encourage you to reflect and share a story about that. As I go through these examples, I want you to reflect and come talking about it. So from our different practice domains, in terms of health equity in public health, smoking cessation messaging, being aware of culturally safe or considerate Indigenous realities and culture, acknowledging the recommendations from the Truth and Reconciliation Committee. The public health nurse works and collaborates with Indigenous peoples to begin a community consultation process. In the home health area, advocating for families of medically frail children who are seeking supports from their local MP to ensure the equity of services, offering flu vaccine to homebound individuals, advocating for wheelchair transportation and accessibility within your community. From the family practice, primary care lens, collaboration to enhance accessibility of resources, advocating within the public sphere, coordination of pharmacy, social worker for financial assistance for folks to provide drug coverage, and then collaborating to address barriers and challenges that are seen in gaps in your community for the clients that you work with. So again, across the different specialties, we're all working using that health equity lens. So again, I'd like to open it up for one or two people to share a reflection on how you demonstrate health equity in your work. Wanting to share a story or a reflection on health equity work?
Hi, this is Shannon. I do health services for community living program in Prince George, British Columbia. And so we work with clients who have developmental disabilities and complex medical issues. We are perpetually working in trying to ensure that our clients are receiving equitable health resources. We're a very, very small team, and with 1.8 FTE of nurses and 1 FTE of OT for the whole Northern Interior region of British Columbia. So that means that we can't do it all.
Right.
But we're very vocal in and very much try to make connections. We do have a primary care model here, and it's been good and bad. It does seem, because whenever they do see the label of developmental disability, they automatically assume that that is somebody that we should be working with. And it may or may not be the case. And so we do a lot of education about how we can support it, but that there is criteria for the clients that we actually are able to work with. So it's just continual trying to see that our clients or clients who may not be in our caseload are getting the support that they need. That's kind of general, but
that's wonderful. Thank you for sharing. And again, we're all cognizant of lack of, I don't like the word lack, but the resources are tight no matter where we work, but there's still ways to acknowledge the little bit that we do and to continue to do our little bit and focus on what we feel is appropriate and best for our clients, and getting that right access and who we can communicate with across the sectors to ensure that that's a part of what we do as nurses. So thank you so much for sharing your stories. We really appreciate it. And hopefully others, I'm sure you all have a story that you can reflect on and bring back, maybe start some discussion at your team. So I'm going to move along here. Again, just the health equity piece, it's such an important core competency for us as community health nurses. And no matter if we're in home health, public health, primary care, that should be one of the principal things that we keep in the forefront and help to support and build whatever means we have in our role within our organizations and within our teams that we work with. So I think I'm transferring over now. I think it's our transition. So my colleague Cheryl will take over now. So over to you, Cheryl.
Thanks, Karen. I'm really pleased that you teased forward one of the two new standards, and that's health equity. It used to be called access and equity. It's now called health equity. That's threaded through every practice expectation and all of the standards. And of course, the other new standard added in 2019 was evidence-informed practice. But what I'm going to speak to are the new practice expectations. Underneath all 8 standards are practice expectations. And what we wanted to do before we move on to more dialogue and more reflecting and more sharing is to tease forward these new practice expectations. And I'll try my best to be brief. Next slide. Thanks, Karen. So the first one I want to talk about is cultural safety. And that can be found in Standard 1, health promotion, Standard 3, health maintenance, Standard 4, professional relationships. In fact, probably all over the place. Cultural safety means that the person we're working with actually feels safe. It's incumbent upon the community health nurse to ensure that they are enacting a way of communicating that reflects what safety means for the person in front of us or the population in front of us. And when we're thinking about cultural safety within an Indigenous context, whether they're Indigenous or not, it means that the practitioner can communicate, that's us, competently with a client where we're really looking at power imbalances, institutional discrimination, colonization, those sorts of things, which then moves into the notion of cultural humility, which is rather different. It always makes me think of rehab nursing, where we were taught to sit on our hands and not do and mobilize our patients to do. Cultural humility is also about the hands, where our hands are open, we are humbled by understanding that we actually are a learner when it comes to understanding another person's experience. It does come from our Indigenous brothers and sisters, of course, understanding that we must be humble. It's a humble acknowledgement, it's lifelong, and it's all about self-reflection. Next slide, thanks, Karen. This, of course, leads into Indigenous ways of knowing, and we can find that in Standard 5, capacity building. We can also find it in our new standard, evidence-informed practice, where we're saying evidence also includes Indigenous ways of knowing. And so a quotation that we've pulled forward from our standards is that Indigenous knowledges comprises a complex set of technologies developed and sustained by our Indigenous civilizations, often oral and symbolic. It's transmitted through the structure of Indigenous language and passed on to the next generation through modeling, practice, animation, rather than written word. So what else did I want to say about this? I had something really important that I wanted to say. Yes, that it has 5 characteristics. It's personal, it's oral, it's transmitted orally, it's experiential, it's holistic, it's narrative. The next new practice expectation broadens how we view prevention. Now, we all know about primary prevention, where our work is to reduce the impact of specific risk factors. And now with a health equity lens, we understand that those risk factors are often structurally caused, socially caused. We know secondary prevention aims to reduce the prevalence of disease by shortening its duration. But what we've added is primordial and quaternary. And I just want to mention what primordial means. It's the prevention of the development of risk factors. So it's looking at before. And quaternary is measures aimed at softening the impact. Sorry about that. It's looking at how we over-medicalize certain populations. It's looking at identifying people or populations at risk of medical mishaps, for example, like over-medicalization. And one thing we really know, we over-medicalize Indigenous populations, we over-psychiatrize women, We definitely over-medicalize persons considered disabled. And so you can see our standards are really infusing equity all over the place. Next slide. I hope that was clear. Another practice expectation comes from our new practice standard of an evidence-informed practice, and that's around critical appraisal. Of course, we know that that's something taught. Thanks, Carl, you're sweet. We know that this is something taught to our undergrad students, but we're wanting it to stay in really front and center in our standards. And this is an ability to really assess where is knowledge coming from, what is the validity of it, what is its relevance to community health practice, and also underneath that, an equity lens is who gets to say what truth is, who gets to produce knowledge in the first place, who's missing, and all of that. Knowledge translation, again, is coming from our new standard of evidence-informed practice. And knowledge translation, we've done this in community health for decades and decades and decades. And we know it refers to a dynamic and iterative process that includes, broad ways to disseminate sound knowledge, that the aim is really about the health of all Canadians, including newcomers. Another new practice expectation is interprofessional competency. And we would find this, for example, under Standard 4, professional relationships. And it really invites us to reflect on what community health nurses have always done, and that's working in teams, understanding their role, and always trying to explain our role over and over. But that's a way that we do that so that we can all work together. And now this is an expectation of everyone now. And then quality improvement. This practice expectation can be found in Standard 8 of professional responsibility and accountability. And this involves us, which we already do, working to improve healthcare delivery, looking at effectiveness, access, capacity, safety, patient-centeredness, and always equity. Who are we missing? Who are we inadvertently blaming? So I think that might be it. Can we see the next slide, Karen? That might be it for me.
Yeah, I think the next
Thank you.
transition over to Lori. Thank you, Cheryl.
Thank you, Cheryl, and thank you, Karen. I don't know if anybody found themselves nodding as we were going through the standards of practice and then the practice expectations, but as I was hearing these things, I found myself nodding and thinking, oh yes, I can see the situation in family practice that I've experienced. And so this is a wonderful opportunity for us to kind of just pause and reflect back. And so I guess my question, you'll see on the far right-hand side, those are our practice expectations. And so I guess this is a great opportunity to invite everybody to, or whoever wants to speak. How have you seen these come to life in your practice? And whether you want to speak to the standards of practice or the practice expectations, but again, kind of opening up that dialogue to the floor here too as well. So just pause and reflect, and please feel free to either raise your hand or unmute yourself and go ahead. I appreciate some of the stories in the chat as well, so I'll do my very best to kind of acknowledge that. And sometimes people aren't able to unmute themselves, so if you can share in the chat, that's really appreciated as well. So how have you seen these come to life, I guess, in your practice as well?
Well, I'll say something. Just one example got me in trouble in public health, and that was we were being pushed, I guess. This is a long time ago, not that long, sort of a long time ago, to push a contraceptive that was through an injection. I'm just going to leave it vague. And we were invited to rely on the insert of the medication as the evidence for its efficacy and who it should be. And of course, I brought that forward around, there's other studies that are suggesting that this is not safe and these sorts of things. So it was unpopular at the time. We didn't have these standards at the time, but I wish that I did have the critical appraisal piece so that we could really unpack and confront possible pharmaceutical influence in terms of what's considered safe and for what populations. And I will say we were being told to promote it at the time to certain populations that now we would say that was racist. So I didn't have the language back then, and now we do. So that's pretty terrific.
Absolutely, Cheryl, such a good point. Does anybody have anything else that kind of comes to mind as it relates to the standards or practice expectations? I know for myself as a family practice nurse in the community that I work in, something that really stood out to me just as a practice expectation is just the importance of, the Indigenous ways of knowing and thinking about, like the respect and reciprocity and things like that, and involving them in the creation of a primary care clinic in one of the communities in Saskatchewan. And so, involving that elder and having that perspective and that conversation and that respect and how it really does impact right from the ground phase up, right? And then it really does have that ripple effect on the community surrounding as well.
Hi, can you hear me?
I can, Anne, go ahead.
Perfect. Hi, this is Anne from Whitehorse. And the one that resonates with me is the professional relationships, especially with COVID. Typically when we're doing mass immunization clinics, it's just CHNs, it's community health nurses setting it all up. And the last 2 years, we've worked really closely with logistics teams, with pharmacists coming on board, providing training for administering vaccine for allied health professionals who've never immunized before. So it's really stretched a lot of our relationships, like in a good way, like we've expanded who we work with, and pharmacists have a better understanding of what we do, what our role is. And, when you have a nurse that's having to do the skills checklist with a pharmacist or someone who's not normally in our team, it's been very interesting, and it's nice to see it reflected in our standards. So just wanted to mention that.
Great point, Anne. Absolutely. So there is a silver lining to this piece of COVID, right? Excellent. Anybody else want to share before I hand our torch over to Tish?
It's Karen Curry. I can share the quality improvement piece for me. My daily work is in professional practice. In our organization, the practice quality and risk team are the same team. So we work really closely at looking at data, looking at, risk events that happen. Fortunately, we do see when things go wrong. We don't often hear about when things are going really well, but part of my work is to help managers and staff to reflect and to see the value in quality improvement, that it's not an add-on, that it should be part of your daily work, and to learn from risk events or to learn from events that didn't go right, and take that back and share the stories with other practitioners, whether it's the adverse medications, whether it's, complaints from clients about conversations or way they felt they were spoken to. It's all looking at it through a lens of learning. So I see that as another way of as well building capacity for our staff to understand how to integrate quality improvement into the day-to-day work. So that one, I think, sometimes gets overlooked. People don't either love quality improvement or it's like, ugh, that's just something else I have to do. So I thought I'd put a positive spin on quality improvement.
I love it, Karen. Thank you. Thanks for sharing some life, you guys, and your stories and reflections and stuff. So with that, Tish, up to you.
Thanks, Lori, Karen, and Cheryl. I've been acutely listening as community health nurses do. And I just want to acknowledge the story from Carol. Carol, what I heard when you spoke about the member of your community that you cross paths with as you're biking, what I heard you say was that you valued his humanity. I heard you say you value his skills. And just in acknowledging that for him, just the power of the capacity you built within that very, minuscule interaction. So that was something I took from your story. From Sherilyn, when you talked about the teamwork, my mind automatically went to the standard around interprofessional competence and skill. And what I heard you talk about was shared ownership of an opportunity. And that shared ownership is something that community health nurses, to use Cheryl's word, it's woven and teased in each of the standards and practice competencies. From you, Kim, what I really heard about was equity and as Cheryl identified, not over medicalizing a unique population. And to do that, what I heard you talk about was strong advocacy for those folks that you serve, and just challenging biases and assumptions, which is certainly the foundation of a social justice perspective. So thank you for that. And then Anne, again, you in your little snippet there talked with us about the importance of interprofessional work, and that's something I'm really passionate about. And to be truthful, it's the reason why I practice in community, because it's about everybody is valued, everybody brings something, and when they are engaged and valued, that can be really a powerful intervention for change and hope, I suppose. So my part of the talk today is to really sort of bring this home, to think about the power of reflection in our day-to-day lives as community health practitioners. And sometimes we work with folks and populations and communities and situations that some might consider messy. And I think one of our superpowers is the lens of seeing possibility, of seeing capacity, of seeing assets, of seeing resilience. And I think there's always a fresh start to every day when you go to work, that you can clean your lens to make sure that instead of seeing a deficit and participating in deficit discourses around your community, can you see the love? Can you see the human connection? Can you see the capacity and the possibility? And I think there are days, I just will be very truthful, and certainly COVID has really driven this home for us as community health nurses, that some days are harder than others to wear love, the love lens and the valuing lens. It is very easy to participate in deficit discourse because there's so much work and so much potential. But I think that a way for you to reignite your passion for clean lens is to really embrace these standards of practice, to become very familiar with them, to exude them, to purposefully, intentionally practice with the indicators that are under each one. And when you are not able to do that, to recognize what was it about the system that perhaps prevented you from doing that. So I'm going to ask you, as we leave this seminar, to take a fresh look at your lens at which you apply and think about your work. So next slide, Karen, please. What we do know as community health nurses is we are all about relationships. Relationship is the underpinning of all of these standards, that regardless, for example, of your ability to critically appraise something, if you don't have the ability to bring that back to a practice relationship, there would be a gap. And so I just want to acknowledge that as community health nurses, this is our superpower. This is what we do. This is what we love. This is why we're here. You know, that we are skilled in respectful, compassionate, authentic, interested inquiry. And as Al said in 2016, so I want to acknowledge that that is interpersonal, but it is also intrapersonal, inside yourself. And so the importance of reflection on action, reflection in action, is where you can really get in touch with your value system around your relational practice. We know that relational practice is collaborative, it's reflexive and responsive. And reflexive means that as I'm unfolding a conversation with somebody, I'm already being affected by that conversation, taking in the meaning of that conversation, and then acting accordingly as I respond. We know that context changes everything. And so community health nursing practice can happen in a clinic, in a car. The most interesting place I've ever worked as a community health nurse was in a very steep concrete bunker with a teenager who was hanging out with boys there. And we were trying to teach her some self-protective behaviors around sexual mistreatment. And it was wet and dark and dingy, but it was very, very important work. And, you know, so context with everything. This is where she was. We had to role play where she was going to place herself in this situation. I've been under a bed with a child. I've been in a closet with a child. You know, I work in a school-based practice setting and with families in their homes. And so, you know, context is everything. And I think that it's important to recognize that as community health nurses, we're aware of that. And we respond and reflect based on our assessment of those contexts. And certainly to enact the practice standards and practice behavior expectations, you need to be contextually responsive. So there's a whole toolkit that goes with that. And we want to acknowledge that you already have that. And if you are new to this practice specialty, this is your job, is to develop that response, contextual response toolkit. So watch your mentors, find a mentor, have conversations, share the stories. And that is where it really comes to life. We know, as Cheryl acknowledged, that there are many structural and systemic barriers for the folks that we serve. And we acknowledge that those exist. We challenge them when we assess. And we are always working from that lens of social justice towards health equity. Next slide, Karen. So I just want to acknowledge that, you know, I'm a white settler. I live in Treaty 6 in Saskatchewan. I have learned some of my best lessons, my best wisdoms from some of the Indigenous elders that we interact with and through the stories they tell. And so this is why we wanted you to start thinking about the power of your story as a community health nurse, and the power of the stories of the folks that you live with and work with and serve. And so I think there are times when we juggle our contexts where we are not able to fully feel confident or always achieving excellence. And I just want to acknowledge that that is a reasonable situation to experience. I think what's important after the fact is that purposeful, intentional, deliberate reflection on action. What would I do differently next time? How can I learn from this? How could I better advocate in this situation? And I think when you are fully present with somebody you're serving, they will know whether or not you value them, just as Carol started out our storytelling this morning. So there are some questions on this slide. I won't read through all of them. I'm going to just give us about 10 seconds of silence. And if you could maybe skim the questions on the slide. And this is a way for you to kind of find an opportunity for yourself, maybe an area where you want to maybe clean the lens a little bit, maybe shake up the value system a little bit, maybe critically appraise something in a different way, maybe collaborate with a different colleague or somebody else that maybe has a different perspective or a different worldview or a different way of knowing. As Donna introduced me in the beginning, I'm an educator, and these are these are questions that I ask my students to reflect on about every 3 weeks in our clinical experience. You know, I ask them to really dig into this self-awareness of where are you at in the nursing service that you're providing, and how do these, once you can really take ownership and navigate these purposefully, how do these reflect your standard of practice? So we'll just give you about 10 seconds to have a quick peek here. And then I would just invite quickly anybody, maybe 1 or 2 stories, if you would like to answer one of those questions about how you operationalize this.
I think first of all, I want to say thanks for using folks, because I interchangeably say community members or folks, you know, so that's I like that language. It's folky, it's folks.
Well, it's certainly a social justice, enact, right? That
Is it?
will value.
Is it?
Yeah, I think so. I mean that, that everybody is valued, and for however or whoever they identify, and so that gender neutrality, I think, is very important. Yeah,
It encompasses that too, then, doesn't it?
absolutely.
So just because because of my knowledge of the CHN practice standards, and because I've been able to scaffold and fit my practice so wonderfully and into the standards, and be able to use the standards to present to other nurses or health allies that what I do isn't just choral being choral. It's like this is grounded in practice standards that I can scaffold my professional relationships with. So I feel like I operate at quite a high level on all the points, and bringing right down to the bottom. Am I transparent and open with my colleagues about my valuing of client perspectives? And this is I'm in a new role, which I've had to resign from because I can't. I feel like there's a conflict of philosophical values around who we are, what is our role with our clients, and I feel like I need to that transparency is understood as is misunderstood, because there isn't the ability for that this practice setting to have conversations around security of just there's such a fine balance between. So the word savior came up, and it got brought up in an agenda item on our nursing meeting, and I had to just speak up directly. I'm like, okay, we can't use that word. Can't use that word on a nursing agenda. That we're gonna talk about savior, how not to be a savior. It's like we need to couch our language in very different very different words, and have a very different approach if we're going to be talking about a hot button word, such a hot button topic. So
Carol, I think what I hear you talking about is when your practice standards and values are operationalizing in a system that doesn't necessarily have the structures and policies in place to embrace, and so there's no consistency there. I think
or a matching of philosophical.
Correct. Yeah.
A social equity piece. Yeah. So go on.
I will acknowledge that this last question is about leadership, right? Of are you prepared to stand on that line and say, this is what I do, how I do it, why I do it, and when I do it, and it really does challenge us in our leadership. I just will acknowledge that. I know there's probably more to your story there than you were able to share, so I'm sorry, but I am cognizant of time. I do just want to acknowledge that, I think that community health nurses can utilize narrative competence to their advantage, which means think about the stories of the people you're serving. Think about how their story interacts, overlaps, or contradicts your own personal story, and where those meet in the middle, because that affects how you show up in relationship as a community health nurse. So I will pass it over to you, Karen, and we'll just finish off very quickly here, folks, just acknowledging time.
Great, thank you so much. Just from our group, we really are very grateful for you for being open and honest and sharing and feeling comfortable in this space to share. So we encourage you to go back to your teams, talk about the standards, talk about what you've learned today, or maybe some tidbits that, hey, I didn't recognize that, or this is something we should be doing more of, or it's okay for us to share our stories because this is part of who we are as community health nurses. And to think about how you can bring this work back to your workplaces, encourage that sharing and support of your fellow folks you work with to be aware. I'm going to put a shout out in closing, our Standards and Competency Committee. We're small but mighty. So if anything we talked about here today, you said, hey, I've got an interest in this and I'd really like to be part of building and sharing and promoting this, please connect with us. You can connect with us through the CHNC email that you just registered for, as well as onto our website as well. And again, so we encourage you to go back to your workplaces, talk about the standards, consider CHNC certification, maybe some study groups with public health or other community health nurses. Include learning objectives that help you build your professional development. If you're a manager of nurses, you know, maybe take a check of your competency review documents. Do they embed the community health nurse standards? Is there an opportunity to do some of that work? Continue to collaborate and talk about how we as community health nurses, you know, have a value in those interdisciplinary teams. Thank you for your leadership today and coming to this webinar and showing up for yourselves. You know, continue to go out there, be knowledgeable, model the behavior, collaborate, advocate, and continue to support other and mentor other nurses who may be new to community health nursing, and encourage folks to continue to stick with community health nursing, because we're all here because it's a great place to be. And we've all learned and grown and taken so much from being a community health nurse. So thank you so much for spending an hour with us. I'll turn it over to Donna for any closing. If there's any closing notes you want to say, that brings us right up to the top of the hour.
Excellent.
If there's any.
Yeah, thank you, Karen and Cheryl and Tish and Lori. That was an excellent session. Great to reflect again on the standards. I was personally thinking that when I heard practice expectations, it seems that our practice has focused around COVID-19. And for me, I thought, good, like I need to refocus and broaden and go back to our standards once again. What else was I going to say? Don't forget the conference. If anyone would love to come to the conference, even if June 8th to the 10th doesn't work for you, the sessions will be taped. So there's always the opportunity to listen at your leisure for, I think it's up to 6 months after, to view and listen to the conference abstracts. So thank you again to our speakers, to the participants that were here today, that shared stories in the chat, comments in the chat, and also you were willing to share some of your stories verbally. So I really appreciate that. It's sometimes hard to do that, but it really makes for a rich webinar. So thank you. And there is one more webinar that's coming up in May before our conference. I think the date is May 12th. That will be noon again Pacific time, 3 o'clock Eastern time, 4 o'clock Atlantic time. So thanks again to our speakers and to everyone, and happy Nurses Week to everyone. Bye for now.